So, very good morning to all. Today, we are going to see two more muscular dystrophies and we are going to conclude the muscular dystrophy over. So, for muscular dystrophy, that now we are going to discuss, we have to discuss first. So, there is facioscapulohumeral muscular dystrophy. As the name itself suggests, fascio related to face, scapulo related to the scapular regions or the scapular muscles, and humeral that is mainly shoulder. If all the three we are going to describe in detail, that will be facioscapulohumeral dystrophy. Yes, so these muscles will be the first ones to be affected. Later on, as we have discussed, these muscular dystrophies they are progressive in nature. So slowly and steadily, other muscles may also begin to incorporate. These muscles can't say, but it will particularly start with these muscles and will continue to be majorly affecting these muscles. What is the etiology? It is a autosomal dominant gene defect FRG1 chromosome 4q35. If you don't remember the chromosome, that is fine. If you don't remember the gene defect, that is fine. But most important, you should remember which type, which chromosomes are affected, autosomal or X-linked, as well as they are dominant or recessive. That will define the course of the disease. Epidemiology, for the first time, females are more affected than males. Right now, we saw females are either carrier because they were X-linked, and if they were autosomal, they were recessive type. This is the first we are discussing is autosomal dominant. એટલે કે આ gene હશે from the mother or the father, 100% the child is going to have this type of dystrophies. And here, females are more affected than males. Clinical manifestation, age of onset, late childhood and early adulthood. Childhood in the late start as well as in the early adulthood. So the age almost is around 15 to 20 years at which it starts. જ્યારે start થશે. Yes, DMD, everything is much more quicker to start in the early phases of the life. No cardiac or CNS involvement. Purely it will be related to motor aspect only. Yes, only the muscles will be affected more. Winging of the scapula can be easily seen. Yes, winging, what is it? You already know, you have already studied it. A photograph I have included that will tell you much more clearly the winging of scapula. Markedly decreased shoulder flexion and abduction. Shoulder flexion and abduction is reduced by, you already know, scapulohumeral. Yes, so shoulder joint will be affected, range of motions will be affected in the stages. Horizontal clavicles, and usually there will be scoliosis. So here, the first thing that you want to observe, see the clavicles, horizontal clavicles. These muscles of the shoulder, yes, completely denervated, or we can say completely atrophied. This is winging of scapula. Yes, you see the inner border, or you can say the inferior angle of the scapula will move more inferiorly when you ask the patient to do a push on the wall. Yes, the scapula should ideally remain in neutral position, but here it will turn medially or even at times laterally. So this you can see because these muscles are weak, muscles weak છે એટલે scapula ને stabilize નથી કરી શકતા, stabilize નથી થતું એટલે winging થશે. This is particular, you see deltoid, you see biceps also, and some portion of the arm also. Yes, that is also being affected. This gives a particular appearance. What we are going to see is also called as appearance. So muscle weakness, face, shoulder, and upper arm, as we discussed. Now, upperથી જ આપણે easily કહી શકાય. Face will be affected, scapular region, that is the shoulder region, humeral, that is mainly the upper part of the shoulder, and the lower part of the shoulder, that is arm, as well as the trapezial muscles will be affected. Spelling, these muscles are not good. So deltoid, you see here, deltoid relatively normal. Yes, the first portion that is marked in the presentation, that is relatively normal. Distal pectoralis major and erector spinae. So back extensors, erector spinae. That is not much of it is affected. Yes. So some portion is left off, some portion is spared. This is again dependent on the genes that are involved. The genes involved, I say, in a lineage, abuse sparing. Yes, it has no particular other reason why these are spared and are most involved. So the appearance which you get from these muscles being affected. That is termed as Popeye appearance. You might be aware of the cartoon. Yes, Popeye. Yes, he used to eat spinach and then his biceps would grow. The same appearance here. This here why it is there because deltoid is relatively spare. Deltoid spare છે એટલે એવું લાગશે કે જેમ Popeye, the cartoon head, that is how he used to show his strength. That is what you will be observing in such patients. So Focal appearance, lack of facial mobility, incomplete eye closure, pouting of lips, transverse smile, absence of eye and forehead, wrinkles. So first, lack of facial mobility, facial expressions or facial mobility. Yes, all the first muscles of the face, as you already have submitted assignment on it. The muscles of the face, they will not be contracted. Why? Because they are atrophied. Atrophied because of muscular dystrophy. Incomplete eye closure, also termed as process. We have described this in various conditions. Pouting lips, yes, the lips remains pouted. You see here, the lips, yes, they remain in pout. Pout is contracted state. This is. You might be aware of how pouting is there. So transverse smile, also one side, if it is more affected or both sides equally affected, that time the smile, which should be like this, becomes transverse. Even if the patient is smiling, you cannot tell why because the muscles are not contracting. The muscles are not contracting. That means because of atrophy, of course. That means you will see the patient smile, but with a transverse smile, not the normal curvature smile that we observe in normal individuals. And absence of eye and forehead wrinkles is for forehead wrinkles, specifically frontalis muscle, that is responsible for forehead wrinkles. That is not possible because of the muscle atrophy, because the face is affected. Diagnosis. First is muscle biopsy and PE. So normal serum CPK. Now CPK level here is the first time it is normal. Up till now it was mildly increased. DMT and DMT is significantly increased. Yes. Here is the first time telling us check muscular dystrophy. There is no increase in CPK level. It will be normal. Natural history, it is slow progression. It progresses very slowly. Face, shoulder, muscle, pelvic tibialis anterior, these are the main muscles to be affected. First is the face. We already saw the features of the face. Smile transverse facet, wrinkles nahi hoy, and also the patient will have shoulder involvement, will have tibialis anterior involvement. Although that is not part of the name facioscapulohumeral, some amount of tibialis anterior and pelvis shoulder will be affected in later stages. પહેલા જ આપણે વાત કરી. જ્યારે patient will start થશે, it will be from face and the shoulder region, but later on it can progress to the other parts of the body also. Good life expectancy, yes, so they almost live up to 60 or 70 years of age. Yes, there is no change in life expectancy. Why? CNS affect નથી થતું, cranial nerves affect નથી થતા, and more important, cardiac muscles are not being affected. Cardiac muscles affect નહીં થાય, lead to normal life expectancy or healthy lifestyle. Treatment, posterior scapulocoastal fusion or stabilization, that is scapuloplexic. These are complex surgery procedures. Those tend to just aim at winging of scapula. Winging of scapula જ્યારે patient માં હોય. Why is winging of scapula considered so bad? Because scapular stabilization નથી. Scapula જો stabilize ના હોય તો કોઈ પણ movement કરવી is very difficult. Yes, you need glenohumeral rhythm. Yes, 1:3 if you are aware of it. Glenohumeral rhythm તમારી normal હોય તો જ તમે full flexion, extension, abduction બધું elevation activities કરી શકો. That is why scapula is so important. Scapula એની રીતે move થશે ત્યારે જ તમારું full range of motion achieve થશે. Otherwise you cannot achieve full range of motion. So at this time, first is the scapulocoastal fusion. That is the scapula itself is fused to the thorax. Yes, એનાથી શું થશે? Stability આવી જશે. Scapula move નહીં થાય. Full range of motion achieve નહીં થાય. Instability છે એ remove થઈ જશે. And otherwise you go for scapuloplexic. That is another surgery specifically for stabilizing the scapula over the thorax, but that allows some amount of motion. If થોડીક motion allow કરશે, થોડાક motion માં full range of motion can be achieved. Near normal full range of motion. Full 180-degree elevation will never be possible for such individuals. એ કરી જ નહીં શકે. તમે ગમે એટલું એને encourage કરશો, no matter which treatments you provide, once the muscle has become atrophied, પછી એ આગળ નહીં. Coming to the next, distal muscular dystrophy. નામ જ કે છે distal. You can see from the figure also. Just affecting the distal parts of the body. Yes, upper limbs and lower limbs. So it is autosomal dominant trait. Second disease we have talked about. It is comparatively very rare. આ ઘણું rare છે. બીજા diseases જે આપણે જોયા muscular dystrophy એના કરતા. Dystrophin, that is MB protein defects. So again a new protein, dystrophin, will be affected, which is again a membrane protein. Yes, membrane, cell membrane protein. Age of onset after 45 years. Yes, so that it was again late in the early adulthood or late childhood. Here it is about 40 years of age, 40 or more years of age. Initial involvement, intrinsic hand, calf, tibialis posterior, three main muscles. Intrinsic hand, yes, calf muscle and tibialis anterior. These will be the first ones to be affected. સૌથી પહેલા આ affect થશે, પછી slowly and steadily, because of the progression of the disease, other muscles also get involved. Spread proximally and nominal or normal sensation. So again, muscles are only or motor part is only affected. No other involvement of heart or CNS. So it is relatively less. One important feature of distal muscular dystrophy is patient સૌથી પહેલા disable થશે. Yes, why? Upper limb કોઈ પણ activity કરવું impossible. Lower limb walking કરવું impossible, because the main muscles of the periphery are responsible for all our smooth movements, accurate movements, coordinated movements, walking, gait, everything will be hampered. Yes, at a disability level બહુ જ વધારે હશે. The patient will be disabled very early. Yes, so few photographs, you can see the intrinsic muscles, the palm here. You can see very clearly they have gone for wasting. You see the thenar eminence, you see the hypothenar eminence, and also the wrist. Yes, you can see the distal aspect of the wrist. That will also tell you that the muscles are affected. Same the case, you see the calves, how they should be and how they are atrophied continuously. Yes, calf muscles જ્યારે પણ involve થશે, may that be pseudo hypertrophy that you talked about, or in terms of affection by muscular dystrophy, that is decreased tone, that both things will be very clearly seen. તમને ખબર જ પડી જશે 100% yes, the calf have been affected, because normally the calf have a good girth. એમાં increase થશે or decrease થશે, બંને વસ્તુ તમને જલ્દી ખબર પડી જશે. And the last we want to discuss is congenital muscular dystrophy. As the name suggests, it is starting from the very birth or initial stages of life. So etiology, it is autosomal recessive. Yes, autosomal recessive. So if father has it, mother does not have it, and the child is born, only there are 50% chances that the patient will have it. 50, yes, 50% chances that the patient should have it. Why? Because there are two chances here will be dominant and recessive, dominant and recessive. Dominant disease will not be there. Recessive disease will be there. So 25, and dominant recessive again no chance. Yes, not 50%. So sorry, it will be 25% chance that the offspring will have the disease. Yes, only 25%. Otherwise, they will be area, because it is recessive type. Epidemiology, it is rare. Both male and female are equally affected. Male equals to female ratio. Yes. You need to remember the ratios also. Why they are important? Whenever you are seeing a patient તમારી પાસે આવશે, you are going to see in the clinics or in the hospitals itself. ત્યારે તમે જોશો patient ને, so you have to think if gender of the patient. If it is a male, which are the conditions and what is the prevalence? DMD સૌથી વધારે, પછી PMD, પછી ring girdle, પછી scapuloin. This is very rare. Yes. તો આમાંથી કઈ હોઈ શકે condition that depends on gender itself. Yes, because of the gene transfusion from the parents. Yes, yeah. Chromosomes normally 23 chromosomes inherit કરી છે from the mother and the father. એમાંથી કયું ડોમિનન્ટ છે, કયું રિસેસિવ છે, અને ડીએનએ ટેસ્ટિંગ પણ ઓલમોસ્ટ બધા પેશન્ટ્સ વિથ મસ્ક્યુલર ડિસ્ટ્રોફી કરાવેલું હશે. You just have to go through it. You see which gene is affected. From that, you can see the gender and you can decide, yes, this is autosomal recessive type. This may be congenital muscular dystrophy. What are the clinical features? Stiffness of joint, congenital hip dislocation or CHD, one of the conditions you will be learning in orthopedics. Stiffness of joint will be there. Subluxation will be there. The difference between dislocation and subluxation. Subluxation is only movement or displacement of the normal joint surfaces from one region to another region, but they are still in contact. The contact is so if this is glenoid fossa and this is humeral head, this moves down, but still glenoid fossa and humeral head are in contact. Yes, so this is subluxation. पर जो completely dislocation मतलब बंदे बच्चे contact ताकि mobile joint dislocate नहीं. Achilles tendon contracture help us equinovarus. Yes, CTED and scoliosis is also common. So you can see the patient whole body is affected from the head to the tip of the toe. Every part of the body will be affected, and this is most severe, but still again a rare condition. So what all things will be affected? First, poor motivation. So we talk about higher mental function. Poor motivation and concentration. Concentration negative patient motivation will be low. Also, the patient has autism spectrum disorder and ADHD. ADHD is attention deficit hypertrophy disorder. Yes, the patient always requires or does things to gain attention. Yes, that is ADHD. And also autism spectrum disorders. Autism spectrum disorders we are again going to learn in future classes. But right now, I want to tell you, they are specifically they are more of okay. Autism spectrum disorder, they are learning disorders. કોઈ પણ વસ્તુ નવી learn કરવી હોય તો language barrier આવે, communication barriers આવે, or the patient has concentration or other deficits. CNS is affected, higher mental functions. At that time, it will be termed as autism spectrum disorder. That's the name suggests. નામમાં છે spectrum disorders. એટલે આની અંદર પણ ઘણી બધી conditions. Yes. Which are they? Of course, you'll be learning in the future. Mental retardation or delay, so IQ is low. Swallowing and feeding difficulties, that is dysphagia. Bowel bladder delays, that is dysfunction. Mostly muscular dystrophy leads to flaccid bladder. Yes. Possible club feet, tight heel cords, AFO precision, AFO, ankle foot orthosis, or even other braces, that is type of orthosis you are going to provide to these patients. Orthosis શું હેલ્પ કરશે? orthosis હેલ્પ કરશે મેન્ટેન કરવા માટે और પ્રિવેન્ટ deformity ફોર્મ કરવા. Yes, that is how it will help. બારથી સપોર્ટ આપશે. We talk the example in PNI. Yes, peripheral nerve injury. જ્યારે રેડિયલ nerve injury હોય હાથ આમને આમ રહેશે તો contracture ફોર્મ થશે. તો તમે orthosis આપશો તો it will prevent contracture because આપણે કેવી પોઝિશન આપી દઈએ છીએ ત્યાં મિનિમલ અમાઉન્ટ ઓફ સ્ટ્રેસ હશે અને જોઈન્ટ રિલેટિવલી ફ્રી હશે. Other things, poor head control. So this is developmental milestone delay. Developmental milestone delay. Ear infection, otitis media is common. Facial weakness is there. Speech problem is there. Respiratory distress may have breathing problem. Mechanical ventilation may be needed. Respiration can affect the intercostal muscles, abdominal, diaphragm. The involve patient. Now that depends on patient to patient how severe the condition is. Floppy belly and poor muscle tone. Yes, the muscle tone, of course, will be decreased because it is muscular dystrophy. Atrophy of the muscles, and that will lead to further more damage or further more reduction in mobility and increase in disability. Diagnosis, muscle biopsy is the way. Treatment, physical therapy, orthosis, soft tissue release, and osteotomy. At times, to prevent or to correct the deformity, we can go for osteotomy. You can see here the patient has CTED, congenital telecoequinovarus. The foot remains in vertical inversion. So here what we can do, we can remove a part of the tendon with the bone such that the foot remains in neutral position. Yes, in neutral position, osteotomy, removal of the bone will be required. These operations and other surgeries we are going to touch in the later on lectures that we are going to cover on surgery specific in neurological. Yes, that is it. About all the muscular dystrophies we have to discuss. Now, if I want to summarize these all things, આપણે જે પણ લખ્યું તે પણ હમણાં સુધી વાંચ્યું એ બધું જ જો summary કરવું હોય તો in two slides and in one table we can just summarize it everything. Yes. So first we are going to see DMD, LGMD, FSMD, distal and congenital. Yes. So starting with DMD, incidence is common. This is much more common clinically seen. Age of onset 3 to 6 years. Gender is male. Inheritance it is X-linked. Muscle involvement, X-linked recessive and proximal to distal muscles will be involved. Where will be the muscles be? Leg, hand, arm, face, larynx, and thigh. LGMD, less common, second decade of life, either sex can be affected. It is autosomal recessive, rarely autosomal dominant. Proximal to distal, upper extremity and calf muscle will be affected. Facioscapulohumeral, not common. It is second decade of life onset. Muscle, male and females are equally affected. It is autosomal dominant. Face and shoulder to pelvis and leg extensor, hip abdominals, quadriceps muscles will be affected in the later stage. Again, distal muscular dystrophy that is rare. Again, 20 to 77 years onset. Again, think about what is the variation? It can start from 20 years, it can start at 50 or even 70 or 70 plus. Yes. This variance makes it very difficult to diagnose because with age, other signs and symptoms like we have discussed diseases like dementia, right? Parkinson, enough signs and symptoms and you have to differentiate. That is termed as differential diagnosis. Exactly what disease છે તમને clinical features, history, આખું assessment લેશો ત્યારે જ ખબર પડે કે yes, this is not Parkinson's, this is muscular dystrophy. So that is termed as what we call differential diagnosis between various diseases with same conditions or symptoms. Muscle involvement is distal and later on it will affect the proximal muscle. And congenital is rare and exactly after the birth, both male and female affected. Inheritance is unknown. It is generalized weakness, as we talked about. Whole body is affected. Yes, in the just right there we discussed that whole body will be affected. Pseudo hypertrophy will be present in DMD 80% of the calf muscle, LGMD 33% of that. Uh, Facioscapulohumeral is rare. The, congenital and distal will never have calf muscle pseudo hypertrophy. Contractions are common only in DMD. Scoliosis is common again only in DMD and LGMD. Heart involvement is there only in DMD, and some portion that we have discussed of other diseases, but not in LGMD, FSMD, BD, or CMD. Intellectual decrease, of course, we talked about the IQ. It decreases in DMD and BMD. It is normal in LGMD, FSMD, BD, and CMD. There will be affection. Its IQ will be lower, and attention span will also be lower. Course of the disease, DMD is rapid and scary. It starts abruptly and moves on very fast. Yes, एकदम fast moves on. See the progression बहुत fast. So DMD comparatively slower. LGMD is slow. FSMD is insidious. BD is benign. Benign means एक बार start करते પછી જ્યારે જેમ maintain the signs and symptoms don't get worse over time. And CMD is again set. Treatment is generally aimed at controlling the onset of the symptoms to maximize the quality of life. So there is no such medication that you can provide specifically for any condition that we have discussed about the muscular dystrophy, except if there is hypertonia, which is rare. So no hypertrophy only. That is also not hypertonia. That is muscle mass going for fat deposition or fat globule deposition. Fat important deposition को अपन से एना लिखे अपन ने लाग से कि yes the hypertrophy is there, but actually there is no hypertrophy. Yes, that is why No such condition can be treated with medication alone. Medications will involve only symptomatic treatment. And symptoms we have discussed all the things. We have discussed medication part in the previous lectures on other conditions, so no need to go in detail for each and every class of drug that will be used. If you remember what are the clinical features, it will be very easy for you to understand which treatment can be given, and more of it remains on physical therapist. And again, as we talked about in the first lecture, sympathy versus empathy. Yes, so you have to be empathetic to the patient, not sympathetic. Always support the patient, but don't give false hopes. What do you think? नहीं आपका patient है, this patient will going to survive. If the patient, of course, has the severe forms like DMD, but if you see that progression is there, you should report it to the neurophysician also, and also the parents that the condition is getting worse. Yes, as much as possible, be transparent to the patient. That will help the patient understand, help the patient gain trust on you and on your treatment. Yes. So this is it about muscular dystrophies. Any doubts you have so far, please let me know. Any doubt? कोई पर वस्तु ना खबर पड़ी हो, please ask. Right in the chat.